Bene, io aspetto che ci sia il collegamento per introdurre, se ha bisogno di introduzione, il prossimo relatore, che sarà per l'appunto il professor Eric Kossof, che credo appunto non abbia bisogno di presentazioni dal momento che è un grandissimo scienziato e ricercatore che ha studiato in maniera approfondita l'applicazione delle terapie chetogeniche nelle epilessie e non solo, e che ha coordinato la stesura delle linee guida internazionali anche sull'applicazione e che ecco, ha accettato di essere collegato con noi oggi. Hello, Eric. Aspettiamo che ci senta.
Hi, can everybody hear me okay? It's hard for me to see. I can't see the room. I want to make sure.
Yes, we can hear you. Hello and welcome to this meeting. It's a great pleasure to have you here. So thank you very much on behalf of the organization. And we would like, well, I have already presented your Lectio Magistralis e il professor Kossof ci parlerà delle indicazioni e controindicazioni alla terapia chetogenica. And so, please, you can begin. Thank you a lot, very much again.
Okay. Hi, everyone. Can everyone see me okay? Yes? And can
Yes.
hear me? Wonderful. So thank you all so much for the kind invitation to be here. This is obviously a big honor for me. And of course, first, I want to give my apologies for not being able to be there for this conference live in person. I am improving. Thank you all so much. Hopefully at the next meeting, I can visit your wonderful city and be there in person. Here in the morning in Baltimore in the United States, it is cold and rainy. I'm sure it's much nicer in Italy for all of you today. I really also just want to give my thanks to Dr. Raffaele Pila, who's been just so kind and nice and helping for letting me be able to still present here today. Francesco Iliano, who's helped rearrange the program. Pierangelo Veggiati, who's also been very kind about allowing the program to be changed so I can give this talk live, not just recorded. And then I really want to give my thanks to Marissa Gambari, who sent me some very, very nice emails. And again, I really appreciate everyone's kindness. And hopefully you've all had a great meeting so far. I will try not to be duplicative, although there probably will be some things that I'll talk about today that may have been covered already this morning. I'm sure this meeting has been amazing, and I will hopefully add a little something new that maybe you haven't heard yet this morning, or may be hearing later from Simona Bertoli in clinical applications next. But I will try. And so I will not cover implementation. That was covered already. I will cover GLUT1. I know Dr. Klepper is here, and I think just recently spoke very briefly, so he's obviously knows more about it than me, for sure. And I will cover history too, Dr. Paoli covered. But my focus today will really be about indications and also a little bit about maybe some contraindications to the ketogenic diet that we have here today. And so over the next 40 to 45 minutes, I'll just sort of cover some of the major ones here today. These are my disclosures. Some are related to the ketogenic diet. Some are not related to the ketogenic diet. Here in the United States, it's very popular. A lot of families are interested in it. It is still a craze for weight loss and diabetes. There are families who come to us asking about it, who sometimes understand what the ketogenic diet is and sometimes maybe are less understanding. But it certainly has become very, very popular here today. And so In 2009, back when we first did our first consensus guideline, we thought it was very, very important to talk about indications. And I'm going to get into that here today. In fact, that was table number 1 of our consensus guideline. This was an international conglomeration of neurologists and dietitians who got together, some of them here in the room, as I know, today, to sort of come up with what we thought was sort of to help manage children on the diet. And I know you've heard a lot about implementation. You're going to hear more today about how to manage children. I'm going to, again, focus more on the indications, so to speak. It's been a very interesting history. I know Dr. Paoli spoke about it. If you do a Google's books search for the term ketogenic diet in the English language, you can see it showed up in the 1920s, became very popular in the 1930s and 40s, and then lost popularity for a lot of various reasons, including new medications and sort of a lack of research and mentorship until really 1994 with the Charlie Foundation and Matthew's Friends. Things really have taken off, and now the ketogenic diet has become very popular. Similarly, the science has also become very, very popular. And in 2018, we decided to revise our ketogenic diet consensus guideline to update what has changed over 10 years and to see if there had been big changes also in the indications. This was officially agreed to and sponsored by the Charlie Foundation, Matthew's Friends, Child Neurology Society in the United States, and also the Carson Harris Foundation, with some new members. Dr. Gazelle, who I know is, I think, speaking later, was a new member. And we also had some returning members to the 2018 guideline. And I think as this guideline was published, there was a recognition in the community that we had lots of information, lots of good science, randomized controlled trials, children, adults, ketogenic, modified Atkins, low glycemic index treatment. And so I think we know as a community, I'm sure you've heard this here today, that there is a lot of good information, a lot of evidence that the ketogenic diet is effective. And so I think what we're trying to do as a community is go to the next level of some of the science, especially for my sake in today's lecture, what those indications and contraindications should be. Now, this is at 6 months in children. Okay, we know the diet can be very effective. This is usually in children who have failed multiple medications. Some of them have gone on to continue to have daily seizures. And we know in all children, in general, we have a little more than a 50%, maybe about a 50-60% chance of benefit, with about 10 to 15% becoming seizure-free, as you can see here. Very, very effective. But of course, we always want to do better, right? We would love to have this pie graph look more like seizure-free, where maybe 50% are seizure-free. That would be wonderful for our parents, for our children, and even for now our adults who are going on ketogenic diet therapy. So one of the things we've looked at is trying to find who these seizure-free patients are. Are there any sort of factors, biomarkers? Most of the data, at least so far today, has more focused on indications and situations, epilepsy conditions, where it seems like you're more likely to be seizure-free. Again, this is from our 2008-2009, the first guideline, Table 1, as you can see here, was epilepsy syndromes and conditions in which the ketogenic diet was reported as beneficial. Back when we published this definition of probable versus possible benefit was 2 publications versus 1 publication. Not maybe as scientific as we could have been. But you can see I think did a very good job of highlighting those situations where the ketogenic diet seemed to be, at least back in 2009, very effective. LUT1 deficiency, PDH, we'll talk about Doza syndrome, tuberous sclerosis, Rett syndrome, Dravet syndrome, infantile spasms, and then formula-fed children, with then as you can see here, 5 other conditions where the diet seems to be effective, maybe not as much published evidence. And so when we revised this guideline, we tried to be a little more scientific about what was an indication. And so in 2018, we actually added a few that we call true indications, where you had at least a 70% response rate from at least 2 different hospitals having 2 different published papers. And so there were, as you can see here, 5 conditions not present back in 2008 that now came up into that indication. Angelman syndrome, complex 1, mitochondrial disorders, fires, Ohtahara syndrome, and superrefractory status epilepticus. These were not there before. Well, mitochondrial disease was but a possible. Now it's an actual indication. Conditions that, if anything, had now more evidence and so remained on the list: Dravet, Doza syndrome, GLUT1, formula-fed children, infantile spasms, PDH deficiency, and tuberous sclerosis stayed on the list because we had enough good evidence to continue that. And then we actually had a table number 2 where we said the diet can be effective, but not necessarily better than a 70% response rate. And this may change if this gets revised again in 5 years or so, but at least right now there does not appear to be sort of at least growing evidence that these, back at least then, should be considered true indications. And so here is what Table 1 in the 2018 guideline looks like. This is meant to be alphabetical, and you can see here these conditions with also the references that were listed here now, where we believe the diet is, very, very effective. For the sake of today's lecture, I'm not going to go through all of them. There's actually very interesting data about all of these, but I'm decided to today I'm going to focus on 4 that I think are maybe some of the most powerful ones in recent years, ones that I hear a lot about in emails and phone calls, some that I see a lot of referrals for. And at the very end, I'll talk about some new ideas, some new indications. We'll, of course, talk about contraindications too, but I'm only going to talk about this 4. And what I'll do in order is I'll first talk about infantile spasms, then I'll talk about epilepsy with myoclonic atonic seizures, or Doza syndrome. I'll touch base very quickly about GLUT1 deficiency, since I know you heard about this just last lecture. And then we'll also talk about superrefractory status epilepticus. So hypsarrhythmia, the classic EEG pattern seen in infantile spasms. We certainly see a lot of this at major academic centers. How well does the ketogenic diet work for this condition? Well, it actually goes back to 1998, one of the first large papers ever published on the ketogenic diet from Dr. John Freeman, my mentor, published a series of 150 children consecutively put on the ketogenic diet over a 2-year period. And in table 3 of this large series of children, he decided to go and look by seizure type to see if there was perhaps a suggestion that one type was better than another. And this is actually maybe one of the first times that infantile spasms was mentioned. Not a lot of patients, okay, only 13. But if you look at that, 8 out of those 13 did very, very well. And so when I saw this back when I was in my training, it got me very excited. I said, wow, these infantile spasms children actually had done very well, even though there was no literature on it to date. And so just about 4 years later, we published our first experience adding 10 more children that we had started, 23 children altogether, mostly males, interestingly. The minority at the time had a symptomatic etiology. Nowadays, we often do find the cause, but many of these children were very refractory. 74% had failed steroids. And this was a paper I published back in 2002, 22 years ago, but showed my early interest in infantile spasms. And we found that it was very effective. So half of the children had a greater than 90% reduction in spasms with EEG improvement, development improvement, and often they could come off medicines that maybe they were on, including sometimes steroids. Interestingly, the majority, vast majority, 88% that had failed ACTH were greater than 50% improved. So these were families that were obviously very concerned. They were, felt to be maybe refractory cases for sure. They still did very well on the diet. Back in 2010, we updated our numbers as we saw our numbers grow and grow. And this is from Amanda Hahn, one of our medical students, where she looked at 104 children by this point. Two-thirds had a greater than 50% response. 37% had at least 6 months where they had spasm freedom. And it was generally effective when it did work within about 2.4 months. If you look at table number 2, where you can see the spasms reduction for these children over time, you can see here, even with an intent to treat analysis and that allowing for people who dropped out of the study, as time went on, it was relatively about a third of children, again, who were spasm-free, with still a large number as well with greater than 90% reduction. And a lot of children were able to stay on the diet even to 9 months, and about half sort of by 9 to 12 months had stopped, sometimes on purpose because they were doing very well. So we've been using the diet quite a bit for infantile spasms, obviously since 2002, but this, I think, really kind of helped bring it to the next level. In a very nice review published from Italy, I don't know if anyone in the audience is one of the authors here, they did a large meta-analysis and review of all of the papers that had been published looking at infantile spasms in the ketogenic diet. Very well done review published in 2017. And they found very similar numbers to what we found in 2010. 65% with greater than 50% reduction, 35% spasm-free. Interestingly, if the spasms were due to an idiopathic etiology, more likely to have the seizure-free or spasm-free response. In our series, we haven't seen that. It seems to be relatively equal, whether it's a known etiology or an unknown etiology. We are kind of open to trying it in both of those children. What about younger children with modified Atkins diets? Generally, we use the classic ketogenic diet in children under 2 years of age. This was a very nice study from Dr. Sharma out of India, where they did a randomized trial of infants who had had infantile spasms that did not respond to steroids, and they either randomized them to try the ketogenic diet or continue drugs as usual, very similar to Liz Neal's study that was published that led to a lot of improvement in sort of the thought process about randomized control trials. So 91 children with spasms, and not a big surprise, 11 out of 46 became spasm-free with the diet, nobody in the control group, and then 30 out of 46 had a greater than 50% spasm reduction, also nobody in the control group. So randomized evidence that in this case, even a modified Atkins diet was more likely than just sort of continuing the drugs as usual in leading spasm-free or improvement. I think even still to date, this is the truth. I think most centers believe the ketogenic diet is a good number 3. Steroids, vigabatrin, and then ketogenic diet. And this was from a consensus guideline published in 2010, where they said that it can be considered an alternative, it meaning the ketogenic diet, when first-line treatments such as steroids and vigabatrin fail or are deemed inappropriate. And they felt that this was a good second-line therapy. Very good evidence for that, I think, from all of this publications. And when you go back and look and you say, well, who's more likely to be in that responder category, right? We looked at, again, as was mentioned, symptomatic. We didn't find that change like the meta-analysis did. It was pretty equal. But one thing that did stand out was the sooner we got to these children, the better. Very interestingly, okay? And interestingly as well, if they had tried steroids, they were a little less likely to respond. But that's typically the situation we use it. But you can see here an average of 2.6 drugs for the greater than 90% responders versus 4.3 drugs tried for those who did not respond, suggesting that getting to these children sooner rather than later might be better. And so I'm going to tell you about a case. This is Carson. I think many in the room may know Carson or heard about her story. In February 2007, she was completely normal, was 5 months old, and then had the acute onset of infantile spasms and was seen in the emergency room very quickly. The EEG I showed earlier, that was her. That was her EEG when she showed up in the ER. The family did not want to do steroids or vigabatrin. We were offering that to them, and we had actually done the ketogenic diet as a first-line therapy before steroids or vigabatrin in a few cases by that point. So we offered it to the family, and they went ahead and started her on ketogenic formula. Within about 3 days, her spasms stopped, and then she stayed on the diet. At 2 months, her EEG was completely normal. We never put her on a seizure medication, and still to date, she has not been on that. And we were able to successfully take her off the ketogenic diet after 6 months. She is now 16 years old, pretty amazing. There's me and my wife with Jerry Harris, her mother, and there's Carson right here. We were having some gelato at a gathering. She's amazing. She's about to graduate high school and go to university. The family has created a foundation called the Carson Harris Foundation to get across the idea that you could do the diet in certain situations as a first-line therapy. We published our results about Carson and other children in 2008, 13 children with the diet, 20 with ACTH. The diet definitely works, although steroids seem to work a little bit more quickly, as you can see here at 1 month. But sort of by 3 to 6 months, the diet maybe looks a bit better. Developmental delay was equal, and the recurrence rate was lower, not statistically so, but definitely was lower than with steroids. This was sort of found in a similar trial from Anastasia Dressler and her team in Vienna back in 2019, where they randomized children to try either the diet or to try other therapies. And for those who had not tried vigabatrin first, and then they were offered the two choices, you can see very similar results, a little bit better, quicker with steroids, but at the most recent visit, it flips and the diet looks very effective. We do still offer this here at Johns Hopkins. If families come in quick enough, we will sometimes offer the ketogenic diet as a first-line therapy. So the second indication that I will talk about is DOSA syndrome. And I often pronounced it deuce, and I was told, no, it is not like a moose. It is DOSA, pronounced doza. And so that is the correct pronunciation of this condition, which I'm very interested in. It is now referred to as EMATS, epilepsy with myoclonic atonic seizures. I still often refer to it as DOSA syndrome. These are young children, typically 3 to 5 years of age, intellectually normal, who all of a sudden start developing drop seizures and larger convulsions. This was first described by Dr. Hermann Dosa, who was the former head of child neurology in Kiel, Germany. And he was a pioneer in pediatric epilepsy who first described this condition in 1970 and called it centrancephalic myoclonic astatic hedymal. He first described it in 51 children and was clear, and I think this is important, that this was not Lennox-Gastaut syndrome. There was in many of these children a strong family history of epilepsy, although I think that has not necessarily turned out to be the case, at least in 2024. There's been lots of names for this condition. 1970, this is what it was sort of called. In 1989, and when I was in my training, it was referred to as MAE, or myoclonic astatic epilepsy. Then it started to change to epilepsy with myoclonic atonic seizures. I would suggest back in 2017 when I did a review, maybe we should call it DOSA syndrome, but I think most people still call it EMA now with a little TS. And the typical story, again, is a child who's 3 years of age, normal development, who presents after a first seizure. For EEG and MRI, often the first time these happen are normal. The second seizure may happen a month later, often started on levetiracetam or another drug, and then the family starts calling pretty soon that they're having these quick head drops, often without necessarily falling. I'm going to show you a video. Hopefully it will work. See that kind of a quick head drop when these happen. You repeat the EEG and now it becomes more abnormal. You see spike wave activity with an otherwise generally normal background. The family is usually then very worried about the child's health and falling and asks about buying a helmet. And then sometimes they can have other seizures, including absence seizures. And usually by the time I see them, they're on valproate or clobazam in combination with the levetiracetam. And this is often what the EEG will look like, bursts of spike wave on a generally otherwise normal background. The child may be referred to as Lennox-Gastaut syndrome, but otherwise is doing well and normal. The family is often then asking, certainly here in the US, about cannabis products, and is then often referred to our center where somebody will say, I wonder if this is DOSA syndrome. Usually once that diagnosis is made, we get them on the diet very quickly. These children do amazingly well. The seizures slow down in this child and stop very quickly. We're able to wean them off medications. This is another one of my star patients. Usually some of my best photographs of patients are children who have DOSA syndrome because they're usually totally normal and very, very cute. She remains on the ketogenic diet for 2 years, and then once her EEG is normalized, we then slowly wean her off the diet. We'd love to see these children come back and see us in clinic. This is actually the same girl back. This was during the pandemic. A few months later, coming back to see us in the clinic. And these are usually, again, families that want to take pictures because they've done just so well. We have lots and lots of photos of all of our families. You can see one girl drinking her formula and one boy even actually eating butter, which we thought was just an absolutely great photograph to have. There's been a lot of recent information about DOSA. That's why I talk about it here this afternoon with Dr. Nichols, Eshbak, and Joshi from 3 different centers, including mine. We added up all of our patients that had this condition and looked at how they did and found that medicines do work. So about 26% will respond to a medication, typically valproate, levetiracetam, and maybe some other drugs. So we do try medications, and I do have DOSA children who do respond, about 1 out of 4. But in our series, when we then compared it to the ketogenic diet, wasn't even close. 3 times as likely to respond to diet as it was to the drugs. And in about half of these children, they eventually ended up on the diet down the road. And we went on to say in our conclusions, not only does this study support the use of diet therapy in the treatment of EMAS, but we would suggest using it earlier in the epilepsy course. You go back to 1970, Dr. Doza talked about, like, well, what happens to these children? And in 1970, he thought the course of the disease is unfavorable. In most cases, dementia develops. And this was back in 1970. The diet was available, but probably, well, definitely not being used widely for this condition. And so this is a statement that I think now we actually believe is not true. This is actually one of my patients coming back to see me, and we love to see these children come back and see us in the office. You know, many of them, excuse me, are doing amazing and going to university and going to college. Okay, the third condition I will briefly talk about is GLUT1 deficiency. I know Dr. Klepper, Dr. Georges are here in the room. Many experts are here. You heard about this, but I think any talk that talks about indications for the ketogenic diet would be a failure if you don't talk about GLUT1 deficiency. In 2020, I encourage all of you to read this great paper. Jörg Klepper was the first author, published in Epilepsia Open, so it's free and open access. And we looked at the ketogenic diet pretty well, I think, in this paper. It's a fair number of paragraphs and tables about the ketogenic diet. And here you can see sort of indications and treatments and how we monitor for children with drug-resistant epilepsy. And you've heard about this as well in your implementation talk. But, you know, we sometimes bring them into the hospital, sometimes do it 2 years, optional LGIT, optional various ways to check ketones. But for GLUT1 deficiency, it's definitely a little bit different, and it is believed to be the first line therapy at any age possible. Not recommended to do the LGIT. Yes, recommended to do blood ketones and check carnitine levels. So a little bit of a difference for GLUT1 versus the classic ketogenic diet for other forms of epilepsy. Again, very influential paper, important to read. We are using this again as maybe the key indication for ketogenic diet therapy. You may have heard about this patient already. This is kind of a star in our GLUT1 community. She's now about 9 years old. This girl here on the left who has been on the ketogenic diet probably technically since before birth. Her mother here has GLUT1 deficiency, became pregnant, stayed on the ketogenic diet throughout her pregnancy, and then as soon as the baby was born, baby was switched to a ketogenic diet and tested and turned out to be positive also for GLUT1 deficiency. Jennifer Kramer, the dietitian, first published this as a poster and then as a paper in 2021 because this girl is now 10 years old and nearly, well, essentially completely normal and has never had seizures and is good evidence, I think, for what early treatment of a pre-symptomatic infant could potentially lead to. Very intriguing paper. Again, you're hearing about some of these indications here today, and you'll notice the theme, right, is like maybe trying it first. Infantile spasms, maybe trying it first. Doza syndrome, maybe trying it maybe first or second. Maybe for GLUT1 deficiency, theoretically here, trying it maybe first. Finally, I'll talk about superrefractory status epilepticus. A lot of people are very interested in using the diet in this emergency situation when we have a situation where epilepsy is not stopping, patients are in the ICU, and their seizures are not controlled, putting them on a ketogenic diet either as a formula or briefly as TPN to try to stop their convulsive seizures. This was a large series from 2018 in the United States, and they found about half of the children who were put on the diet seemed to respond. Generally, we have a protocol. The protocol is similar for children and adults. This was a slide loaned to me by Dr. Mackenzie Cervenka. We use the same protocol in children, where basically we remove the dextrose from the IV fluids, switch their formula to a ketogenic diet. 4-to-1 usually is what we do, formula, although there's been studies that say 3-to-1 may actually be okay too. We check some baseline labs, make sure carbohydrates are removed from the medicines, start to give them vitamins, check their glucoses and ketones, and then give them a week to see if the diet can either get them out of the status epilepticus or maybe try to wean them off of the pentobarbital or ketamine or whatever midazolam drip that they're on. We do this, certainly relatively frequently when the ICU asks us to. This was a very nice review from Natasha Scholler and Helen Cross and the team in England looking at what's our denominator? How often does this work? They found 85 out of 141 done in England responded, and that's kind of what it seems to be study after study. Again, about a 50% chance that this will work. When families ask, that's what I tell them. When this was published in 2021, they found no relationship to the age or, interestingly, the ratio, although, again, we still tend to use a 4-to-1 ratio at our hospital. They were more likely to respond in this series if they were female and more likely to respond if they had a shorter period of status epilepticus as well. Again, suggesting getting to them sooner may be better. So those are the 4 indications I will cover today. There definitely are some other ones I wanted to mention. There's definitely some that we're not so sure about, but I think that could change over the next few years. Autism, Alzheimer's disease, migraine, brain tumors, most recently bipolar and psychiatric conditions. We decided in our consensus statement to really not make any strong statements back in 2018. That could change. We said that there's growing, but not at least right now for us as an epilepsy community to say that we believe it's effective for these conditions. But I think there's growing evidence that it actually may be the case here. Pregnancy, some people are very interested in this, especially our adult center. I'll show on the next slide. There have been 2 case series. Back in 2018, we didn't say that we felt it was safe in pregnancy, but again, this does seem to come up a lot. People are asking maybe this is a potential indication to try diet therapy because certainly we know a lot of our seizure medications have a fair number of side effects if you're pregnant and can be risky to the baby. Maybe the ketogenic diet could be okay there too. What about adults? We have a robust adult epilepsy diet center. Some people say maybe adults should be considered as an indication, adults with refractory epilepsy too. They have their own consensus guideline where they talk about how a lot of the similar indications we see in children will continue into adulthood, and that's not a big surprise. This center has been open now for 14 years, over 400 adults. About 20% come to the center already on a diet, but 80% are brand new and usually are started on the modified Atkins diet. Lots of interesting research into lipids and pregnancy through the Adult Diet Center. So I've spoken already for most of my talk, and I'm almost finished, about these indications. Do they matter? Are we reading this are doctors in the world reading this indication list and referring these children and adults for diet therapy? So we decided to look at this, and this is actually from a poster that was at our San Diego Ketogenic Diet Conference. Dr. Rebecca Steinman, who's now in Delaware, was the first author on this, and this is an interesting study where we actually looked at sort of our referral patterns and looked back at the 2008, 2009 ketogenic guidelines to see, were we seeing more over time in the 10 years before 2008 versus the 10 years after 2008. And the pre-guideline is sort of, as you can see here, kind of the sort of light blue, and the dark blue is after the guidelines. And you can see that there were 4 conditions, 4 indications that definitely increased as a result of the 2008 guideline, statistically at least. Formula-fed children, GLUT1 deficiency, Dravet syndrome, and Rett syndrome. A lot of others did go up, but not statistically. DOSA definitely seemed to go up, but it just wasn't as much. Infantile spasms was pretty steady. We kind of continued to see that. And this is, again, just at our institution. We also looked at who were referring after the guidelines. And this is here before the guidelines, 256 children, and then after the guidelines for 10 years. And if they met the criteria, if they had a indication that was one of the guideline indications, they are in dark blue. So you can see here before and after. Definitely we are seeing more, we saw more children who had indications. We also looked at Johns Hopkins ketogenic diet referral, so some from me or one of my team, another neurologist at Hopkins who's a referrer, or an outside hospital, someone in the outside community. And if you look, you can see the biggest increase by far came from people at our institution who are not necessarily members of our ketogenic diet team, suggesting that we were probably doing a good job of telling other neurologists, trainees, giving local talks to our people, but maybe need to do a better job with some of the outside hospitals. And that's something that I think we are certainly trying to do, is give talks to other places and tell them how effective it can be. Another possible indication, something we are looking at, is absence epilepsy, also new onset. This is a trial that is ongoing at Hopkins, 3 months, prospective, single center, children aged 3 to 12 who have new onset absence epilepsy. What will parents do if given a choice? Will they go on ethosuximide, the common therapy first, or will they try diet therapy? That's sort of one of the aims of the study, is to see what parents will do. Can we teach a family to do the modified Atkins diet pretty quickly, and then obviously see how effective it is? So stay tuned, hopefully soon, for results from this study. Finally, there are, of course, contraindications to the ketogenic diet. I will cover just very briefly here at the end. They're from Table 3 of our 2018 guideline. You can see the absolute contraindications to the ketogenic diet. Most of these are metabolic conditions. And then there are some relative, as you can see here in the bottom, contraindications to the diet. Inability to maintain nutrition. We'll talk about surgery in a second, non-compliance, or if they're on propofol and maybe it's a status epilepticus case. Probably the most common reasons that I will sometimes say no are number 1 and number 3, where maybe I have concerns about the family's ability to do the diet, or I have concerns that maybe they're malnourished and they're not going to be able to eat the diet or stay on the diet. And this is tough. This is tricky to figure out in advance. We do the best we can, but this is something where I try to meet the families before and just really make sure that they're committed. Surgery is something that has come up quite a bit. Rebecca Steinman, who actually helped with the paper looking at the consensus guideline impact, published this with me back in 2007. She looked at 45 children who could have surgery. They were surgically approachable. 25 eventually did have surgery, and it was highly, highly, highly statistically significant that they were more likely to respond in a dramatic way to surgery than to the diet. Doesn't mean the diet wouldn't cause a 50% reduction, but it was very unlikely if the child had a surgical approachable lesion, a tumor, Rasmussen syndrome, a major cortical malformation, that the diet was going to lead to seizure freedom. And in fact, they were less likely to stay on the diet 10 months versus 18 months, probably because of the lure of potentially having surgery. This was actually repeated the next year out of Korea, and they also found good results, okay, that they actually had 19% become seizure-free with the diet, but a lot of these children still went on and had surgery, and 59% seizure-free with surgery, again, versus 19% with seizure freedom. So this is, I think, pretty well known in our community that, surgery, is probably better than the diet if you're looking at seizure freedom. Doesn't mean you can't try the diet, doesn't mean it wouldn't be potentially effective. We actually surveyed our ketogenic diet consensus group, and actually back in 2008, 58% would offer the diet to a child who had a surgically approachable, compared to now 40%, so it dropped in 2018, would offer it to children with a surgically approachable lesion. Still, 40% is pretty good. I think, there are certainly a lot of centers that a child, the family maybe doesn't want surgery or is refusing surgery, would still offer the diet. It's just probably less likely to cause seizure freedom. That is sort of the end of my talk. I'll sort of wrap up. If you would like more information, I know there's representatives from all of these groups here today: Charlie Foundation, Epilepsy Foundation, Matthew's Friends, and of course, INCS, the International Neurological Ketogenic Society. I'll show a slide on that in a minute. You, of course, can review our Epilepsy Open paper from 2018 for much more information about the indications and contraindications that I did not have time to cover here today. All of the references are in there, and again, it was a work done by many of us, including several that are here today in the room. For more information as well about our new society, hopefully you've heard about here today, INCS, I encourage you to go to neuroketo.org for good information, links, websites, and papers as well. Hopefully many of you were at our San Diego meeting, and if not, a lot of that information is available. I think about to have some of the videos and talks go live. These are some photographs from the meeting, including myself here with Dr. Pilla, who again has been incredibly kind to me with this lecture and allowing me to be able to present to you guys today virtually. I hope to see all of you in Paris at the next Ketogenic Diet Conference. Will be held in September of 2025. And then, of course, I really want to make a great shout out to my Ketogenic Diet team that has really been instrumental in all of the work that we've done here today. And so with that, I will end my talk. Again, it's my pleasure and honor to be here. Hopefully you'll learn from Simona Bertoli more about some of the clinical applications. I'm sure you'll hear some similar information. And I'm available for questions if I can hear them, and I will stop sharing my screen. Thank you all so much.
Thank you very much. Abbiamo tempo per un paio di domande, se ci sono, e credo ci sia anche il traduttore, no?
So I'm here if there is a way to have questions. I'm glad to try to answer.
Sì, Valentina, c'è il microfono. Per favore, grazie.
Hi Eric, can you hear me?
No, no. Cioè c'è solo un microfono da cui ci sente.
Okay, maybe it's not possible.
No, ma ci
Massimo,
sente o
I don't
no?
know if people can put something in the chat or I can hear the audience. I'm glad to answer a question, but if not, I'll end my
Ok,
talk.
allora chi vuole fare la domanda si deve avvicinare.
Okay. Hi Eric, how are you? I'm Valentina. I don't know if
Hi,
you can
Valentina.
see me.
No, I can't. I'm sorry, I can't. Hi.
It is always a pleasure listen your lecture since we can feel and see your passion to ketogenic diet throughout years. So thank you so much.
Thank you.
We have here plenty of auditorium. You cannot see, but
I can hear well though.
and I have
Yeah.
a very practical question to you. Since you very well explained the different indication, especially for the epilepsy and status epilepticus and so on. Therefore, I have a question on your attitude on discontinuation. Obviously not when the ketogenic diet doesn't work, or if you want also to give us a comment on this, but when the ketogenic diet works, after we know 2 years, we should try to discontinue the diet. But I would like to understand your attitude, for example, patient with other comorbidities maybe, or other particular condition, obviously a part of GLUT1 deficiency syndrome. And also your protocol for discontinuation.
Yeah, no, excellent question, Valentina. And I know Stefan Alban is trying to do a sort of a multi-center survey to try to get people's thoughts about this, because everyone does things a little bit differently. And we did try to address it a bit in our guideline, but generally you are absolutely right, Valentina. At 2 years, we at least start in children, okay, for most epilepsies, trying to question whether maybe the diet has sort of done its job. Oh, hey, Valentina, there I can see you. Has maybe been helpful, in terms of, and has done what it needs to do. And so for most epilepsies, usually at 2 years, we at least talk to families about it. There are so many things that change that, right? So if they have GLUT1 deficiency, then no, we would not take them off. If they're formula fed only, I can tell you a lot of times they don't want to stop because it's easy and they're doing well and the formula's covered by insurance. Those children often are our long-termers. They stay on the diet longer. Or, they've had like a 90% response. So they're still having seizures and maybe they're not on any medicines, which is amazing. The families get very nervous, right? On the flip side, there's data from Korea that says infantile spasms you could stop at 6 months. They randomized children and 6 months was just as good as 2 years. We certainly for, DOSA syndrome, sometimes we'll go a little shorter. Status epilepticus, if it works, we'll keep them on maybe 6 months. But, in general, I try to keep them on for 2 years, and I think I do it usually over about a month or 6 weeks, just carefully while the family keeps in touch, just to make sure they do okay. It's a very good question, because again, especially with these indications, although we'd say, wow, the diet is so good for it, that doesn't mean it's forever. It doesn't mean that you have to be on the diet forever for all of these. Maybe GLUT1 is the exception. Or PDH too. Thank you, Valentina. Good to see you.
Ci sono altre domande? Nessun'altra domanda? Ah sì, professor Klepper, prego.
Okay.
The Michael.
Okay.
Eric, hi, can you see me?
Hi, Jorg.
Hey, how are you doing? You're missing
I'm doing better.
Especially you're missing the espresso together with me somewhere in the
I know.
Right? Okay.
Thank you.
We have been discussing on terms of GLUT1 deficiency the possibility of adding ketone salts and ketoesters in times of maybe ketotic crisis, operations, dietary mistakes. What's your experience with keto salts and ketoesters?
Yeah, nice question, Jorgen, and great to see you. We've been using them sparingly. I've had a few GLUT1 families that have asked, at the conferences or, the ones I see in my clinic about, could some of these ketone, they tend to use more the esters, at least in the salts is what I've seen, just in terms of less volume. I haven't had a lot of great success yet, but my numbers are so small, it's maybe 4 or 5 children where the family is, trying to do something to get the ketones up. They are, very frustrated because, maybe it's a teenager and it seems like they're staying to the diet, they're compliant, but the ketones are dropping. I haven't had a lot of success with it yet. Think of maybe one family where they think it had some benefit. They are expensive. You know, they're not usually covered by at least insurance in the U.S. So I tell the families to try it if they want, but after a month, if it's not helping, you
Yeah,
know,
well,
just
it's our experience that they increasingly come and ask for these compounds,
Yeah.
or want to discuss and want to know if there is consensus or an opinion on that.
Yeah, not that I'm aware of, not yet. Yeah,
Okay.
good. Good to see you. Thank you.
Bene, ci sono altre domande? Altrimenti... Ah, sì, certo. Ah, dottor Pilla.
Hey, Eric.
Hey, Raphael.
Great to see you, and congratulations for your talk. It was just amazing as always.
Great.
Thank
I'm
you
glad
very
everyone
much.
can hear me okay. Great.
And thank you for connecting live. I mean, it's just impressive. Thank you very much. Just a quick question, because it just came up to my mind. I wasn't going to ask this question, but it just came up to my mind. We've been discussing about the possible applications of the ketogenic diet. I was just wondering if you had any experience on the use of ketogenic diet on depression. I know that it's more of something that, you know, interests adult people and adult audience rather than children. But, you know, it just came up to my mind because I was talking to a neurologist, a friend of mine. We've been working together on the ketogenic, possibilities, ketogenic therapies. And he actually asked me that like a couple of days ago. I don't have much experience on that, so it just came up to my mind. So do you have any, any elucidation you can give us?
Yeah, Franson, thank you. Thank you so much, Dr. Pillitz. And it's so nice to see you. It was a big topic, as you probably remember, at the San Diego meeting. The number of people interested in psychiatry and diets was huge. Lots and lots of people at the meeting, lots of lectures. It's very interesting because if you talk to many of them, just like we were with epilepsy, trying to find, and sort of today's lecture, trying to find indications, they're also trying to find indications within psychiatry. It may not be that all aspects of mental health respond to diet. I've heard certainly they're very interested in bipolar. I know that. Maybe the ups and downs, but like depression, maybe not. I don't know. I think they're very interested. It's beyond my expertise, but I often do, ask them questions, schizophrenia, anorexia. These are things I've heard sort of thrown around. But I think it's still in its infancy. I think we don't know yet for sure which of these conditions may respond to diets, and, why and which diets and what mechanisms may be very different than for epilepsy. I think that was kind of the way we were, 25 years ago. We said, try the diet for everything. We don't know. Now we've gotten a little more precise, as the indications have shown. And I think that's probably what's likely for their field in the next 10 years.
Thank you very much.
Thank you. Yeah.
And great to see you.
Good to see you too.
Grazie a tutti. Dottor Gusel, prego. Sì, deve accomodarsi là purtroppo. You have to go there in order to be able to speak. Just a moment, okay?
Hello, my professor. How are you?
Hi, Orchida.
Today I have a presentation about genetic epilepsies. And,
Yes.
While preparing my presentation, we did a statistic in our center who finish 18 months and who have a genetic disease, genetic mutations. And we saw that after 3 months, we saw the decrease of the seizure number and duration. And normally we say the families after 3 months, maybe pediatric neurologists know same. After 3 months, if it's no effect, we will finish the ketogenic diet. But we, in this statistic, we saw the decreased the seizure number after 3 months and duration. Maybe we have to insist the ketogenic diet to our patients, and maybe we have to encourage them to stay on diet. What do you think?
Wow, you know, that's a very interesting point, because no, you're right. Usually we tell families, you know, even sometimes by 1 month, right? You know, you should see benefit, but a lot depends on the number of seizures, right? If they're having a seizure every day, you would, you know, hope you'd see benefit. But no, I think Orchida, you're right. I mean, I have some patients that it seems like it took longer, and I don't always know why.
Yes.
You know, and the family did not want to give up at 1 month or 2 months, and they started to see some benefit later on. Sometimes I wonder, maybe, you know, I start in the winter when kids are sick, and I should wait, you know, because kids are always sick in the winter. And for some families, you know, the first month is tough, and they don't always get things right. So I think you may be right. It would be very interesting, you know, for you, you know, to publish and to know what, maybe there are some epilepsies that do take longer. You know, infantile spasms, especially again when we use it new onset, I give it like really 7 to 10 days, because the lure of steroids
depends
tough,
on the mutations. For example, GLUT1 deficiency, it's more easy to stop the seizures, but in Dravet syndrome or CDKL5 mutations need time to stop the epileptogenesis, or limitation the epileptogenesis.
Yeah, no, it's and practically it is tough, right? The families are frustrated 1 month, 2 months, and they're still not seeing benefit. And, you know, it is, we try to keep them on it. It's very tough with the lure. There's so many medicines now, so many medicines that, you know, a lot of the families, you know, after a few months, if they're seeing zero benefit, they want to give up. But you may be right. Maybe we should try harder.
Okay, see you. Bye-bye.
Thank you.
Thank you. Thank you.
Bye.
Your nice presentation.
Thank you. Thank you.
Ci sono altre domande? Mi sembra di no. Quindi non so se mi sente il professor Kossof o no, e volevo appunto ringraziarlo tantissimo per il suo tempo e per essere stato con noi oggi. Thank you very much, Eric, for being here and for your lesson. So everybody here is very happy to having listened to your nice lesson. Okay, thank you very much, and I hope to see you soon.
Me too. Thank you so much.
Okay, thank you so much.
Thank you, Matt. Bye.